Bismillah ar-Rahman ar-Rahim. This is one of the very interesting journals that I encountered. Really, it was including a lot of parameters that monitor the hemodynamics with important outcomes. So today we are going to discuss the comparison of predictive powers for mortality between systemic vascular resistant index and serum lactate in children with persistent catecholamine-resistant shock. And this is the first article that I encountered that it is discussing both lactate and the systemic vascular resistant index. Because previous articles, they discuss different predictors of mortality and focusing on lactate. And it is already proven that lactate, one of the predictors of mortality in children with septic shock, and in general, children with critical illnesses. So this article was published in the Biomedical Research International Journal, 2020. So what is being studied? What was the main objective of the study? Here they aim to analyze the association between hemodynamics and serum lactate at different time of points and 28-day mortality in children with persistent catecholamine-resistant shock. So they try to record these the different hemodynamic parameters, the serum lactate at different points, and correlate these readings with the mortality, 28-day mortality in children who had the persistent catecholamine-resistant shock. The methods, what was the study design? This was a retrospective cohort study using chart reviews of children. They included children with the age from 1 month to 18 years. Presenting with shock, the PICU of Changcheng children. This was in Taiwan. And the duration was long duration for this study. It was between January 2008 and December 31, 2017. And whenever there was a change in the definition of septic shock or in the management, they already changed their interventions for the study and change their definitions for the things. So this table, this is the important table because this will include the demographic and the initial hemodynamic parameters between survivors and non-survivor groups. Right. The total number of the study group population, it was 26. The survivors were 12 and those who died were 14. And median age was around 12 years. And majority of non-survivors were males compared to females. And the PRISM score was comparable between the two groups, the survivors versus non-survivors. And if because they in their study, they tried to define the focus of infection, where was it? So the majority of patients were having a bloodstream infection, both among survivors and non-survivors. And the others are minority. The respiratory CNS infections among survivors was 0, and the abdominal and other sites were less. But the majority of the infections were located in the bloodstream. And the pathogens that they detected among survivors and non-survivors, they detected both gram-positive and gram-negative. Viruses were 0 detection among survivors, while 1 among non-survivors. And then unknown organism was just comparable between the two groups. There was no major difference. And for the use of inotropes, the predominantly used inotropes were dopamine and epinephrine. And also comparable, comparable numbers between survivors and non-survivors, we use the dopamine and epinephrine. And the other inotropes, nor-epi, dopamine, dobutamine, mirinone, to lesser extent. And vasopressin was used, was not used for survivors and was used once in non-survivors. And then also they discuss the outcomes. they recorded the outcomes, the ICU stay, and the length of stay in days. The length of stay in days was longer among survivors, and the ICU stay also was longer among survivors. And then here we come to the important cardiac characteristics, where they were documenting to know the correlation between these cardiac characteristics, the hemodynamics parameters, and the mortality. So the vasoactive inotrope score, and it makes sense that the vasoactive inotrope score was higher among those who died, and they were more tachycardic, those who are having mortality. And mean arterial pressure was lower among those who did not survive, and lactate was much higher in the mortality group. And I think all this makes sense, because we expect those who are having, who require more inotropes, who were more tachycardic and hypotensive with higher lactate, that their chances for survival less. And then the initial hemodynamics parameter, the cardiac output was comparable between both groups, survivors versus non-survivors. And the cardiac index also was comparable. There was no major difference between the two groups. And the global ejection fraction also was comparable between the both groups. And the cardiac function index also comparable between the two groups. Because they divided the hemodynamics, they measured the cardiac output, and then the parameters that tells you about the cardiac contractility, such as the cardiac index, ejection fraction, and the global ejection fraction, and the cardiac function index, also they measure to see if there is any difference between those who survive and those who did not survive. And then they have the preload parameters, which include the global and diastolic volume index, also comparable. There was no major difference between the two groups. And diastolic volume, this is just to tell us about the preload of the 4 chambers of the heart. And then the intrathoracic blood volume index also was comparable between both groups. And one of the important parameters that they measure is the stroke volume variability. And there was significant difference between those who survived and those who did not survive. And simply, just to simplify things, the stroke volume variability is the variability of the volume of this ejected by the heart variation. We have a normal variation which occurred during inspiration, expiration, and this happened because of the change in our intrathoracic pressure during inspiration, expiration. And this, when we interfere and mechanically ventilate patients, this variability will change because we are applying positive pressure ventilation. So still the variability will be there. And this was studied before in other studies, and it showed that it can predict those who had the fluid responsiveness. And if the stroke volume variability is less than 13, this carries a favorable outcome. And we can see here the stroke volume variation was around 10 in those who survived, and it was higher in non-survivors. It means that the response was less to the therapy. And then also they compare the afterload parameters, mainly the systemic vascular resistant index. And we know that the systemic vascular resistance is the resistance against which the heart should pump the blood. And here, among those who survived, the systemic vascular resistance was higher. Compared to those who did not survive, they have a much, much lower systemic vascular resistant index. And then also they include the lung parameters, because we know that once you have a patient who is critically sick, whether due to ARDS or septic shock, if they have the volume overload, then they can have a higher mortality rate. And this was proven also by multiple researches before. So this one is the extra vascular lung water index. And there was no major difference between the survivors and non-survivors. And then this is the pulmonary vascular permeability index, because we know that with the inflammation, with the illness, and the cytokines released during the septic shock or RDS, you have the integrity of the capillary bed between the alveoli and the adjacent tissues is broken. So you tend to have more permeability. But here there was no major difference between the two groups. And I do really admire this article, because all the important parameters that might affect the outcome of the patient, they encountered here. So if anything not clear, please stop me at any point and I'm happy to explain.
I think we may continue now, Doctora, and we'll keep maybe the discussion after the topic, I guess.
Okay. Were all variables under study defined well? Yes. They put clear definitions. They said the fluid refractory septic shock was defined as persistent shock despite up to 60 ml per kg of fluid resuscitation based on surviving sepsis campaign 2012. And catecholamine-resistant shock was defined as persistent hypotension after fluid replacement and the support of one kind of vasoactive agent. Persistent catecholamine-resistant shock was defined as a persistent hypotension after the use of two kinds of vasoactive agents. So it's very clear that if you give your patient 60 ml per kg fluid resuscitation and still they have the shock, so this is a fluid refractory septic shock. And if you already did the fluid resuscitation and supported with one vasoactive agent, and still the patient is having the shock, this is a catecholamine-resistant shock. And then if two agents, this is a persistent catecholamine-resistant shock. Were all important variables which affect the study outcome included? Yes, I think yes. All important variables that can affect the study outcome were included. As we have shown in the previous table, the Prism score, the site infection, initial vasoactive inotropic score, the heart rate, the hemodynamic parameter of the PICU. PICU technology, this is produced by Germany in Munich. This is a technology which uses basically the thermodilution to measure for you the hemodynamic parameters. And it is the abbreviation for the pulse index continuous cardiac output system. Currently, there are two systems that can measure the hemodynamics. One of them is the PICU, the other one named LW1000. Also, they measure the outcome, the length of stay in the hospital, and the PICU and 28-day mortality. So what I think that all important variables were included here. Just to make people at the same page, the measurement of this PICU parameters and serum lactate. The PICU system was executed within 2 hours of enrollment, and this system needs only two things: that you will have a central venous catheter, like the internal jugular, for example, and then you have an arterial line. And here in this study, they put the arterial line in the femoral artery, and then the CVC was the internal jugular. Then 3 cold boluses, each bolus 15 ml, 0.9 saline at a temperature of below 8 were performed for each calibration. And the calibration was performed at least every 8 hours or following an unexpected change of hemodynamics. And then the continuous parameters of the systemic vascular resistance index, cardiac index were recorded, and exported to a computer using this PICU software. And then here, because you will give this bolus through the venous, central venous access, and then you will, the system will measure the drop in the temperature once it reaches the arterial end, and it will give like a graph. I did not see this technology, but I can imagine. What measurements were studied? The hemodynamics parameter obtained by a PICU system included the following, which we showed in the table previously. The global end diastolic volume index, we said that this one, it will give you a better estimation for the preload, because it will measure the preload in the 4 chambers of the heart. And the intrathoracic blood volume index and the stroke volume variation, we talk about it thoroughly, and the cardiac parameters, the cardiac output, the cardiac index, and the global ejection fraction, and the afterload parameters, and the systemic vascular resistance, and also the parameters of the lung, because we know that if you have overload in the lung, it's going to affect the patient volume overload. It's going to affect the patient adversely. So they included the extravascular lung water index and the pulmonary vascular permeability index. And the serial hemodynamic parameters during the first 24 hours were analyzed. What are the results? So they did all these things to see what factors can predict the mortality well. During the 10 years study period, 26 children, 13 males and 13 females with persistent catecholamine-resistant shock were monitored using this PICU system. Of this patient, 14 died within 28 days and 12 survived. There was no significant difference in the mean age between the two groups. And the most common site of infection, as we mentioned earlier, was the bloodstream infection. And microbiologically proven infection were observed in 83% of the survival groups compared to 78% of the mortality group, which is comparable. Dopamine and epinephrine were the first and most common used vasoactive and entropic agent, with no significant difference between the two groups. And the initial cardiac characteristics showed higher vasoactive and entropic score and lower MAP and higher serum lactate in the 28-day mortality group than the survival group. And we have seen this in the table. And then this graph shows us the cardiac index. Here, the cardiac index. And the time. The blue line shows us those who survived, and the green dotted line shows us those who did not survive, the mortality. And as you can see, there is no major difference between the two. But if you come here to the systemic vascular resistant index, those who did not survive, the green dotted line here, they have a lower systemic vascular resistant index. And those who survive, they have a higher systemic vascular resistant index. So this means that it is a possible predictor of mortality, the systemic vascular resistance. But the cardiac index doesn't vary too much between the two groups. And then we have the vasoactive entropic score between the survivors and the non-survivors. Those who did not survive have a higher vasoactive entropic score. And this makes sense because they are their septic shock is refractory. They need more entropic support, and you are escalating because they are not responding. What are the results? Still, we are discussing the results of the study. Correlation between lactate and hemodynamic parameters. When they analyzed the correlation between all the hemodynamics measured by the PICU system and lactate, there was a statistically significant correlation between the cardiac index, systemic vascular resistant index, and perfusion pressure with the lactate. And Furthermore, the systemic vascular resistance index had the best negative correlation with the lactate. What this means? Means that when you are having a higher systemic vascular resistance, you are having a lower lactate, and vice versa. Then the survival analysis. We compared the predictive power of the initial systemic vascular resistance index value and serum levels of lactate for 28-day mortality. The initial systemic vascular resistance index had a larger area under the curve than lactate. The systemic vascular resistance, the area under the curve was 0.923. And for the lactate, it was 0.82. Both of them can predict the survival versus mortality, but the systemic vascular resistance index was more powerful than the lactate. So this is a graph which shows us the area under the curve. And here, as you see, this is the one for the systemic vascular resistance, and this is the one for the lactate. Lactate area under the curve is less than the area under the curve for the systemic vascular resistance. So it is a better discriminator between mortality and survival. The best cutoff value of initial 24-hour systemic vascular resistance index for predictive mortality was 1140 and 1284. Because once you are having a predictor, you would like to have what is the cutoff values that tells me which group at higher risk, which group at lower risk. When sepsis progressed to persistent catecholamine-resistant shock initially, the 28-day survival rate was only 7.7 when the initial systemic vascular resistance was less than 1140. After 24 hours of treatment for persistent catecholamine-resistant shock, a systemic vascular resistance index lower than 1284 was associated with poor survival, whereas the outcome was favorable when the systemic vascular resistance increased to more than 1284. So it means that this number, readings above it, correlates with better survivals. And this number, readings below it, correlate with mortality. And then this the best predictive power for different cutoff point of systemic vascular resistance index in persistent catecholamine-resistant shock at each 6-hour interval within the first 24 hours. So here you have the time from 0 time to 24 hours, and you have the different readings for the systemic vascular resistance. Where here we have the, this is the positive likelihood ratio, and this is the negative likelihood ratio. And then maybe this graph will explain to you the cutoff points better. Because here in your left, you can see the blue line is those who survived, and the green dotted line is those who did not survive, the mortality group. No, sorry. This is not the survival, not survival. This is the cumulative survival rate here. This is the days, and the green dotted, the systemic vascular resistance, which is low. And here, a higher systemic vascular resistance. So the cumulative survival rate will decline when you have a systemic vascular resistance less than 1140. And the cumulative survival rate will be better when you are having a higher systemic vascular resistance index. Here it is the same theory, but for a different cutoff point, which is the one which is more than 1284. So the cumulative survival rate is better when you are having a higher systemic vascular resistance index. Type. after all these things that we know this lactate, both lactate and systemic vascular resistant can predict the mortality, and the systemic vascular resistant more powerful than the lactate. Will the result help me in caring for my patient? Yes, because I will put at the back of my mind when managing the patient, those who are having a lower systemic vascular resistant index and hyperlactemia, they are at higher risk for mortality. But I will use this with caution. Can the result be applied to my patient care? The answer is no, because here this study, although it is a very well established study, but it has some limitation. One of the limitations that this study included a small number of patients, only 26, and it is a retrospective study with the possibility of missing data. Although when I read the journal, it did not say that they missed some data, but there is a possibility if you are doing something retrospective. So better to be a prospective, ongoing, you are monitoring your patient and seeing what are the results. And if it is a multiple center study, it will be more powerful, so that if you study it in a larger group, maybe the results will change, because the small might not reflect all the things. And this is the end of our talk. So I hope that it was a clear journal, and I would like to thank Dr. Ayman for giving us this nice article to discuss, because it discusses important parameters in an important disease. And septic shock still carries the worst prognosis when it is severe with poor predictors.
Thank you, Dr.